Okay, so we have today Dr. Raja Selvaraj and Dr. Ajay Naik as the moderators for this very interesting session. And these are two interesting cases with their review that two excellent people, Kartikesan and Ajit Thachal, have done. So over to you, Dr. Raja and Dr. Ajay, to take this forward. And Preeti, please put everybody on mute except for the moderators. Please go ahead, unmute yourself and go ahead.
Yeah, good evening, everyone. And for this next session of the IHRS web series, we have two interesting sessions. First is Dr. Karthikesan going to speak on interesting case of fetal neonatal tachycardia, review of literature. And the second would be by Ajit Thachal regarding Brugada syndrome. So without much ado, we'll start with the fetal neonatal tachycardia. These are problems which are vexing when they appear every once in a while, and we really need to be on our toes to take care of both the fetus, the newborn, and the mother. So go ahead, Karthikeyan.
Thank you, sir. Let me share. Is my slides are visible, sir?
Yes, go ahead.
Okay. So, respected chairpersons and media colleagues, good evening, one and all. At the outset, I would like to thank for our madam for this opportunity. So today I'm going to talk about this another this lockdown period. You know, the short span of time I came across few cases of antenatal cases with the fetal tachycardia. So I thought we'll share this my experience as well as some review of literature, which Dr. Ajay already said. It is very important as we need to save both the mother and fetus, and more of emotional things are involved while managing these cases. So my case was the 26-year-old female is a primary gravida at 31 weeks and no obvious comorbidity and absolutely healthy lady. And her ECG and echo was normal, and she was no routine antenatal scan was performed with the obstetrician on a regular antenatal checkup. And this was the things were noticed and the 31 week of gestation. The rate was pretty high and it was going very fast, and so the Doppler showed the heart rate of roughly around 222 beats per minute, and you can see this Doppler, it's 222 beats per minute. When we put when she was referred here, our center, so to take care of this issue, and when we did a fetal echo, some further fine tuning of this echo, and we could one of the advantage of doing echo for a fetal echo is with our single cursor we can cut both atria and ventricle, so that we can see that the atrial rate as well as the ventricular rate very clearly. In this case, you can see the upper thing is the ventricular rate, which is roughly around 222, which I mentioned. At the same time, we see in between that the atrial rate is around 2.5 beats, roughly around 450. So double the rate of more the atrial deflections than the ventricular deflections, you can see very clearly here. Even you can see here, mother's heart rate is ECG has been connected. It's 100 beats per minute. Within the 100 beats, it's almost 4.5 atrial deflections. You can see 1, 2, 3, 4.5 deflections. It's roughly approximately 450 beats per minute. So the atria is definitely going at a much faster rate than the ventricle, and the Doppler shows the ventricular rate is around 222, which qualifies could be a flutter with the 2:1 conduction. Again, cutting across the intra-atrial septum and the atrial wall, it clearly shows the atrial deflection of the intra-atrial septum as well as the LA wall, which clearly shows that when between the mother's ECG, which is running at the 93 beats, I know we can see the 5 deflections. Again, it qualifies the atrial rate of 450 beats per minute. So when we clearly diagnosed this Doppler as well as the M-mode echocardiography, which easily establishes the diagnosis of fetal atrial flutter with the 2:1 conduction. So again, we involve the obstetrician to do the detailed antenatal scan. So it confirms that atrial as well as ventricular rate plus fetal growth was adequate for a gestation. And there was no evidence of eye drops in the form of any effusion or ascites or any scalp thickness. All those routine things were followed. There was no evidence of eye drops. And there was no cardiac anomaly. And these sort of cases, what we expect is sometimes Epstein's anomaly or ventricular septal defects or some other complex congenital anomalies can be coexistent, yet AV canal defects. These are some of the coexistence and someone develops atrial flutter. Those things were clearly ruled out in our case. So this fetal, when you talk about fetal tachyarrhythmias, which was first recognized in 1930 by Hyman et al., it was published in American Journal of Obstetrics and Gynecology, and it was recognized as a fetal abnormality when the routine in those days, no sophisticated things were not there. When they just listened to the fetal heartbeat, they rate some fetuses developed a very faster rate than the routine other regular fetus. So that's how they labeled as a fetal tachyarrhythmia, some subset of pregnancy, which is prevalence to be 0.4 to 0.6, much lower in, it's not quite common, it's a bit uncommon, 0.4 to 0.6. The main mode of establishing the diagnosis is mode echocardiography. With the added facilities, the Doppler, we can clearly establish a diagnosis of fetal tachyarrhythmias, and we can differentiate in the form of share and also what sort of arrhythmias are going on, which we can clearly ventricular arrhythmias or atrial arrhythmias or ectopics or ventricular ectopics or atrial ectopics, all sort of things we can able to diagnose with a simple echocardiogram. So, but sophisticated things like a fetal magnetocardiogram, which is not available freely everywhere. It is sort of special ECG without any magnetic forces involved here, but the fetal heart generates some magnetic field. So there are special magnetic proof room, the fetal cardiac activity, which generates a magnetic field, which is captured and nullifies that with the mother's fetal cord, which also generates a magnetic field, which is nullified, then generates a complex, which is fetal magnetic cardiography, which needs special equipment, again, which is not easily available everywhere. Maybe sophisticated centers must be having it. Obviously, I don't think enough of our Indian centers having this facility to do fetal magnetic cardiography. So, which is if it is available, it's an easy tool, also to see the clear, some decent way we can recognize both P, QRS, everything can be recorded. We can easily interpret these things. But in the absence of that, and we have to rely on the mode echocardiography and the added Doppler effect to establish the diagnosis of fetal tachyarrhythmias and subclassifications. So normal fetal heart rate varies in 120 to 160 beats at 30 weeks. As fetus sort of growing at the term, it reaches slightly drops to 110 to 150. So to qualify the definition of fetal tachyarrhythmias, the fetal heart rate has to be above 180 beats per minute. So 170 is slightly abnormal. It beats if it crosses 180. So we have to define, we can define as a fetal tachyarrhythmias. One of the major vexing problem is the fetal height drops. So it is 30 to 40% incidence, and it may go higher in some subset of tachyarrhythmias, and it has a very high mortality. That's where we get into a problem in the fetus, late recognition, late treatment, or failure to treat it. All those things attributes to the early onset of tachyarrhythmias, incessant tachyarrhythmias. All those things attributes to the development of fetal height drops, and then which has a very high mortality. Overall mortality is around 8 to 9% in terms of managing fetal tachyarrhythmias. So broadly, we can speak as it can be supraventricular, which is more common. Ventriculars are very rare, except some sort of myocarditis or cardiomyopathies or long QT syndrome. So those cases are reported with sustained arrhythmias, but those things are very rare. But more common is So more common is a supraventricular arrhythmias, more common, and non-sustained as well as sustained. It's not necessary, all the arrhythmias going to be sustained. It can be sometimes non-sustained. We can, while doing the antenatal scan itself, they can notice that some short spurt of the short running ill-sustained arrhythmias can be noticed, but it can be sustained also. The most common which we come across in our practice is so the things which are referred to us as a cardiologist or electrophysiologist, supraventricular arrhythmias and atrial flutter. One other study which is prospectively looked into the antenatal scans, specifically looked into the proportion of fetal arrhythmias, which showed that most common arrhythmias was the PACs. Even as I mentioned, mode or Doppler, clearly we can recognize the PACs, which is the most common thing and doesn't even need any treatment, and it is a benign, and most of the time it disappears as after, even before delivery or after delivery, it disappears after the neonatal period. So other common is the sinus tachycardia, and the most common, as I mentioned, the SVT, supraorbital arrhythmias, thing, and then atrial flutter is very rare as our cases. Atrial flutter is very another rare thing we can see in fetal tachyarrhythmias. When you talk about SVT, the most common SVT is can be of AVRT, and apart from that, AVNRT, PGRT, or atrial tachycardia also can be we can encounter, and the most common is the AVRT. Incidence is more than 2/3 of the SVTs are fetal arrhythmias are SVTs. In this, rate goes about 200 to 300 beats per minute, and then so because of this incessant nature, and it is also early in onset. So if this if it goes unnoticed, the incidence of fetal height drops as high as 64% has been reported. 30 broadly it is around 30 to 60%. The most common reason for this tachyarrhythmia is the height drops is SVT. Most commonly it's AVRT or something, and incessant in nature, which is failure to control or failure to respond to treatment or failure to recognize it. So, or inappropriate treatment, all those things attributes to the development of height drops, which carries high mortality. One such case we came across a 30-week gestation. We can see clearly a mode shows a and B relationship. When we measure the A and B relationship, so VA is correspond to the RP, and AV is AV interval is a PR interval. So long RP, short RP, you can classify it. And mostly short RP tachycardias are AVRTs, and long RPs are either a PGRT or atrial tachycardia, such we know that. So we can broadly classify whether a short RP tachycardia or long RP tachycardia, either by M mode, replacing the M mode, or by Doppler. We can see the VA interval and AV interval, we can measure it, and then we can see that is a long RP or short RP tachycardia. In this patient, we can see the 1:1 relationship between the atria and the ventricle, and the atrial rate is around 230 beats per minute. So next comes the 1/3 of the fetal tachyarrhythmias, supraorbital arrhythmias, or atrial flutters, where the atrial rate goes up to 250 to 300 beats per minute, and then it's most often it's a variable conduction, 2:1, 3:1 conductions. Very rare to have 1:1 conductions. That is the reason the height drops is not as common as SVT. SVT is incessant, and it is very fast and early in onset. On the contrary, to develop a macro-enteral re-entry circuit in atria has to reach certain size, which happens only around 30 weeks of gestation. So the most of the flutters are reported around 29, 30 or beyond 30 weeks of age. And then each child, and the rate is also be controlled with 2:1 or 3:1. And the drugs also, we can control the rate. Even if you are not able to achieve the sinus rhythm, we can control the rate so that you can prevent the development of fetal height drops. And the fetus also by 34 weeks can be premature delivery also can happen. So because of that, the mortality is also low, and the height drops also less in these flutter cases. So when you come to the management, so the mostly we prefer to do transplacental route by peroral administration via the mother, and which is the most common way of treating the patient. This is the first treatment of choice. Our aim is to obviously we try to establish the rhythm back to sinus rhythm, but it may not be possible in all cases. In those cases, if you fail to achieve rhythm, at least if you are able to control the rate, that is also improves the height drop status or prevent the development of height drops, and then it's a highly mortality can be prevented. So it can be achieved by the transplacental route by peroral. Very rare to give IV medication, but most of the time peroral medications. The second choice is transumbilical cord injections of the drugs, or transamniotic fluid, or intraperitoneal injection, or fetal intramuscular injections like digoxin can be intramuscular can be given. And the last the thing is transfetal cardiac injections. But by the time when the fetus needed this sort of treatment, we don't. Obviously, it is the second choice. When you go to this stage, by the time the fetus is very sick, and the mortality is also pretty high in these patients when they needed this sort of treatment. The most common, even though we have big armamentarium of many drugs in our antiarrhythmic drugs, all the drugs are not going to cross the placenta and reach the fair amount of serum level in the fetus. So the drugs which are reach decent level is, so fetal versus maternal plasma drug ratio, digoxin, flecainide, and sotalol, which are all more than 0.9%, which is a very good transplacental transfer and reaches the fetus. So these drugs are preferred. The digoxin, flecainide, sotalol, the more common drugs are used, to treat these supraventricular arrhythmias. And the doses are pretty higher than the regular dose what we use for even adult patient. In digoxin, it has to be given 1 milligram as a loading dose within 48 hours. Then maintenance dose will be 0.375 to 0.5 milligram per day. And flecainide is 200 to 400 milligram per day. And sotalol is 320 milligram per day. We can try to reach it. When any of these drug fails or combination fails, the amiodarone institution as the last resort, and the loading dose is around 200 to more than 2 grams in over a period of 2 to 7 days. Then maintenance dose of 400 to 800 milligram per day as a maintenance dose, because it's a very poor placental transfer, so it processes the very poorly. So it has been very high dose of the given. But the most commonly drug used are digoxin, flecainide, and sotalol. The aim of managing these patients are to prevent fetal height drops, ensure the safety of the fetus, and ensure the safe delivery. So this has been achieved either by restoring sinus rhythm or at least by adequate rate control to prevent the development of height drops. Very important study, so I like to highlight, this is one of the large, more than 159 fetal arrhythmias, in that it's managed by 111 patients, where this study is shown 3 different institutions. So this study, as we mentioned the previous slide, the most common drugs are used: digoxin, flecainide, and sotalol. They were chosen the 3 institutions combinedly, and multi-center non-randomized study was conducted. In that, they clearly shown institution 1 favored the sotalol, other institution favored digoxin, other institution clearly preferred the. It is left to the choice of the thing, but the institution protocol favors this drug. The third institution preferred more of flecainide, second institution preferred more of digoxin, and first institution preferred sotalol. So these patients were analyzed. So the outcome, there are certain nutshell. The outcome of this non-randomized study with the 3 different drugs clearly showed that SVT was significantly better controlled by transplacental medication than atrial flutter or atrial flutter. SVTs are better controlled compared to atrial flutter. The most important thing is flecainide and digoxin were associated with superior conversion rate of SVT as compared to sotalol, and is better tolerated in patients, but and also it reduces the ventricular rate. Even if it failed to achieve the sinus rhythm in these patients, it controls the ventricular rate as a flecainide as a standalone, or digoxin as a standalone, or if you combine both also, it's a better rate control is achieved, and better conversion also achieved in this combination or as a standalone drug. Sotalol is associated with the higher termination, AF termination. Sotalol was shown to be higher prenatal termination, but it is failed to control the rate. Either it's all or none phenomena. Either it converted to sinus rhythm or nothing it does. It's a role of controlling the ventricular rate in a fast, like in our case, like a flutter. Controlling the ventricular rate is very poor with sotalol. Either it makes into sinus rhythm or it fails. So in that contrary, flecainide and the digoxin, either it converts, success also high, or it can at least controls the ventricular rate. Fetal height drops and incessant SVT are independently associated with slower concern. The patient develops height drops. We know that the placental transfer of especially digoxin is very poor, and the conversion also takes longer time, and more fetus spends time with the flutter, more worsening of heart failure, and it becomes a vicious cycle, and the mortality goes up. In this context, yet another study is really high dose flecainide. As we know that flecainide is a very powerful drug, which is most preferred by most of the institutions. And where they tried is a higher flecainide, most effective treatment of fetal tachycardia. Where they did the importance of this study is 48 cases of SVT has been tried with as a monotherapy. Most of the patients were treated with monotherapy, and some patients were treated with the combination with digoxin. When they treated 48 patients, 21 patients were in high drops, which is a very high number. In that small 43 patients, 21 patients were in high drops, because we need to know how to manage these high drops as well. When they present to us with the high drops, we need to know how to choose the drug as well to have the better outcome. So when they flecainide as a monotherapy, high dose means the 400 milligram. Initially they started off the 400 milligram per day with the divided doses for initial 3 days. Then the 4th day onwards they reduced to 300 milligram per day as a single agent. When the patient when there is no fetal height drops, this high dose has a very good outcome, 90% success rate. 9 out of 10 patients reverted to sinus rhythm in SVT. When they have the fetal high drops, again, still 70% of the patient, at least 12 patients achieved sinus rhythm. The medium time take to achieve sinus rhythm was only 3 days. The single drug, when even high drops patient and flecainide reach the serum level because of the high dose within high dose, then we reduce the dose to 300 milligram per day, which convert to 70% success rate. In another 4 patients, they combined with the flecainide versus digoxin. Both they combined, and 4 patients they tried. All 4 had a high drops. All 4 reverted to sinus rhythm. So the author substantially says that flecainide starting with the high dose for 3 days, then reducing to 300 milligram per day, reaches the fetal serum level higher dose, and it makes it successful treatment. And there is no difference in converting into sinus rhythm, either both high drops as well as no high drops. Contrary, the previous study shows high drops takes a longer time. So in this study, when you start with the higher dose of flecainide, there is no difference in between conversion high drops versus no high drops. Put together all the studies, this meta-analysis was performed by Tariq et al., which clearly they selected 10 important studies, which is worth for the meta-analysis. All the studies you can see retrospective studies. And the number of patients are not very huge, only 100 odd patients, or most of them are below 100 patients. Below 100 patients, and this small number of patients accumulated over the period of more than 10 years. That means, so even the highly specialized center also not getting many cases. The worth noting is all that studies has included digoxin and flecainide. Digoxin is the cornerstone of managing this patient. It's because of the safety, and it's the second most common drug used was the flecainide. Only 4 studies included sotalol. Only 2 studies included amiodarone. So this was the thing, and you can see the Flutter numbers are very few. Only 2 studies has a decent number of Flutter patients. Eye drops were also very few, and this only 1/3 of the patients. A few centers had a significant eye drops patient as well. So the drugs, which I already mentioned, the usual loading dose is 1.5 to 2 milligram or 24 to 48 hours were followed in this all the study protocols, and then followed by the serum digoxin level to be measured 1 to 2. Usually the recommended is 2 to 2.5 nanogram per ml serum level should be maintained for the maternal serum level. For flecainide, you can up to 450 can be tried. Again, the therapeutic and the toxic level of digoxin as well as flecainide is very narrow. So it is recommended to monitor serum levels of digoxin and flecainide when we treat the mother with these high doses of medicines. So the serum level has to be 0.2 to 0.1. But again, in reality, flecainide monitoring may not be possible in many centers. Sotalol up to 320 milligrams be tried. You can see the majority of the patients received in the 537 patient fetus, they were analyzed. Fetal tachyarrhythmia, sustained fetal tachyarrhythmias were analyzed. Majority of the patients received digoxin. Next common drug was used was flecainide, and the sotalol was less, and the amiodarone was very few. And there is a significant fetal eye drops also were there, and the Flutter numbers was very few. Which clearly shows that when you include all the fetal tachyarrhythmia patients, including Flutter, including SVT with eye drops, without eye drops, all those things, clearly digoxin termination is lower than the flecainide. So flecainide is flecainide and sotalol's success rate is 60 to 65% as a conversion rate, as against the digoxin, which is only 50% conversion rate to sinus rhythm. So this meta-analysis again shows that digoxin has a lower termination. The tendency towards flecainide is better. And digoxin sotalol, there is no much difference in terms of SVT. There is no difference in digoxin versus sotalol. When you flecainide versus sotalol, if you try, there is a trend towards more conversion to flecainide, which are showed maybe around 65% conversion to flecainide, around less than 60% with the slightly better than digoxin, but less than flecainide. Sotalol falls between the digoxin and the flecainide. When you remove the eye drops patient, because we know that eye drops is a different subset of patient, the drug penetration things are different. Even with the non-eye drops patient, the flecainide scores over digoxin. And again, there is no difference between the digoxin and sotalol. And even the eye drops patient, flecainide scores over the digoxin. So with eye drops or without eye drops, flecainide scores over digoxin in managing supraventricular arrhythmias. When you talk about Flutter as a subset, only 2 studies included a decent number of Flutter patients. When here there is one study showed clearly favor of sotalol, another study showed there is no difference between the sotalol and digoxin. So there is no conclusion being drawn which drug is better, but there is a general agreement that in Flutter, sotalol scores over digoxin in favor of conversion rate. So our case was managed based on my previous limited experience. I started off with the 0.5 milligram of digoxin on day 1, and then subsequently I wanted to give another 0.5 on next day, but patient by the time developed some nausea, vomiting. So I just reduced to 0.25 on next day, and the day 1 onwards, I started around 100 milligram TAD flecainide. And continued fetal heart rate was monitored and every 4th hourly. And day 4, nothing much happened except one breakthrough of slight drop in the heart rate to 180, and except most of the time patient was having 200, heart rate was maintained. And day 4, I slightly increased the dose to 400 milligram per day, maintaining the same digoxin and increased the flecainide. On day 5, the heart rate dropped to 126 beats per minute. Then I immediately arranged for a fetal echo to ensure that there is 1:1 connection is there. Then the lower sinus rhythm has returned, because we have to ensure the rate is getting controlled or rhythm is reverting. So that can be demonstrated only by echocardiogram by recording a mode and Doppler. So here it clearly shows 1:1 AV conduction, and then Doppler also showed both the E and A wave, and there's a clear 1:1 on both, the rate of 129 beats per minute in this patient. The patient, this was all happening at the 31st week of gestation. So I discharged the patient with 300 milligram per day of flecainide and digoxin of 0.25 milligram one day, and we measured the serum digoxin level. It was fairly around the acceptable level. So then we told the referral doctor to monitor the fetal heart rate every weekly, and it was luckily it was maintained with that dose. And 38th week, patient came back to our institute to be admitted and had a normal delivery with the 2.5 kg or 2.7 kg of male baby was delivered with a normal delivery. And this was a neonate ECG. There was absolutely, it was okay. There was no problem of QT. Everything was normal, and there was no any cardiac anomaly or anything. And we didn't start any medication. We observed the patient for patient's mother state for 3-4 days, and within that period, we regularly monitored the patient's fetal heart rate, neonate heart rate also. There was no arrhythmias, and generally the recurrence rate are very rare in this patient. We know that these patients with structurally normal heart, the recurrence are very rare. There is a majority of the consensus agreement says that there is no need to give any medication. Some school of thought is give some antiarrhythmic medication for 6 months and then stop it if there is no recurrence. But overall agreement is to have a careful vigilant watch for next 6 months if there is any recurrences or relapses happening. If there is nothing, its long-term outlook is very good in these patients. And majority of the people agree that there is no need to start any empirical antiarrhythmic medication in this patient. And then one more, this another patient is diagnosed at the age of 36 weeks. This is a tachycardia, but the patient reached that term. This is other area of issue. The patient reached that term when you encounter this problem of fetal arrhythmias. There is a general agreement that it's better to deliver the baby and then manage the baby separately. So as expect this patient, even though the precious baby, it's another 2 weeks were there for expected date of delivery. But once was antenatal scan showed that fetal tachyarrhythmias, the obstetrician took a call. The fetal has grown enough to survive outside, so they took the patient for elective LSCS and delivered the baby. And then we gave adenosine reverted, but subsequently again it was an incessant tachycardia, needed propranolol, digoxin, as well as because only baby was only 3 kg weight. It's a very small dose of beta blocker plus digoxin, plus then not responded for even 72 hours. Then we had introduced small dose of flecainide to control this tachycardia. So in summary, drug preference in tachyarrhythmias clearly shows that flecainide is more effective than digoxin, may be used as a first line of treatment in fetal tachycardia management. So especially SVTs, now flecainide scores over that digoxin, and it can be used as a first treatment of choice. Whether you start with the regular dose or initial high dose with the taper after 3 days, that is individual choice. But again, the non-hydropic fetal eye drops, both flecainide more effective than digoxin. The digoxin is definitely in the fetus eye drops is a poor penetration rate. So mostly it should be used along with the flecainide, or flecainide can be started as an individual drug. And the maternal side effects, so it's very difficult to ascertain the side effects of the flecainide in maternal because the patient develops eye drops and refractory, incessant tachycardia. Overall mortality is very high. It's very difficult to attribute the disease due to drug. There are incidental reports of fetal bradycardias and deaths have been reported, but that is why the flecainide dose has been immediately reduced to 300 milligram. And the combination of digoxin with flecainide, it is always preferred by many physicians to reduce the minimize the side effect of the flecainide. So that's why, and that's what the choice of treatment in these patients. Thank you.
Thank you, Dr. Karthikeyan. I think there was a
fantastic case, and you did a good job of going through a very stepwise approach of evaluating and managing these patients. And if I may sort of summarize the stepwise approach you took, you first confirmed tachycardia by an M mode, and then using M mode or Doppler to identify atrial and
I'm not able
ventricular
to hear you,
activity.
Raja.
Can you hear me now?
I request everybody to put their mics on mute except for the moderator and the presenters. Somebody's mic is on and there is a lot of background noise, please. Thank you.
Okay. Can you hear me now?
Yeah, now better, yeah.
Okay, fine. No, I was saying, so it's a very good case illustrating, the challenging scenario of arrhythmias happening very early in life. And you did a very good job of going through a stepwise approach to management of these patients. And sort of to summarize the steps, so the first is to confirm that there is tachycardia, and then using either M mode or Doppler to visualize simultaneous atrial and ventricular activity, you identify the mechanism of tachycardia. So that if you have A more than V, it's an atrial arrhythmia. If it's V more than A, ventricular arrhythmia. And if you have a 1:1 AV relationship, you look at the VA interval and identify what kind of tachycardia it is. And other key things to do in the fetal echoes, look for hydrops, which is essentially heart failure, and to look for structural heart disease, both of which will influence the prognosis. And then the treatment is usually with drugs which are primarily administered maternally, and there are mainly 4 drug contenders: sotalol, flecainide, digoxin, and amiodarone. And as you went through a lot of literature regarding this, the consensus seems to be that flecainide is the preferred drug of choice, and probably can be used best is to use it in combination with digoxin. And the typical drug doses are much higher than the usual doses we use in adults. So I just have sort of one question, and then I think after that we have some questions here in the chat box. So I'll go to those. So one is, like you said, for most of these, at least these first 3-4 drugs, the plasma level ratio, maternal to fetal ratio is almost 1, right? So
Yeah.
why is there a requirement for a drug dosage which is about 3 to 4 times higher than what is given regularly for an adult? I mean, do you have any idea mechanistically why a higher dosage is required?
Yeah, but still is not, it is, so I mentioned is a 0.9, but it is not exactly 0.9. It may be 0.7 to 0.9. So it will be of higher side 0.9. So it will be still, it may not be exactly 1:1, still we may be 0.7 to 0.9%. So that's why we need, and many of the other drugs doesn't even transfer. So even the slightly higher dosage, and majority of our experience, maybe I have a limited experience in other people, those who are public literature also, even though they mentioned that you can go up to 450 milligram of flecainide,
right.
The majority of the patient doesn't need that. Majority of the patient, with regular doses, they get converted in regular doses. Exceptional cases, especially the problem of hydrops develops, then you need to dose goes to very high.
Treat very aggressively.
I think if I may come in here, I think the typical ratio for DIG is fetal to maternal levels are 0.8 to 0.9. For flecainide, it's around 0.7. Sotalol, it's around 0.3, 0.4, and amio, it's around 0.2 or so. And in hydrops, it's even less. So
transfer is even less,
Sotalol is not that low. I think it is slightly higher. It's not 0.3. It is nearly 0.8, 0.7. So Sotalol is a very good drug. Sotalol. But people are not, again, as compared to the chart which I shown, the preferred drug is digoxin for the safety. So then comes flecainide. Third only comes sotalol, and the last one comes amiodarone.
So another interesting point, Karthikeyan, is in other pregnant ladies, if they require, if there's an indication for beta blockers, we are always worried about fetal bradycardia. But when we are talking about fetal tachyarrhythmias, there's not much data regarding beta blockers for fetal tachyarrhythmias. And why is that? Or has it that already been tried and then people are moving on to DIG and flecainide, and there is more data with that?
I think again, maternal transfer is the third with the beta blocker, I believe. So, and other drugs are verapamil, some centers tried verapamil, propafenone, those drugs are tried. But hardly anybody tried with the beta blocker, probably because the maternal transfer to the fetal transfer will be very poor with beta blocker. That is the reason I think hardly anybody tried with the beta blocker as treating the fetal arrhythmias in these cases.
So another important point would be monitoring the maternal well-being. With DIG and flecainide, generally they say that, okay, you monitor the PR, it should not go more than 200 milliseconds. You're looking at the QRS also. So how would one typically manage these patients in the hospital? And subsequently, when the patient is sent home, how often do you monitor? The idea is to bring them to 36 weeks in some way,
Yeah.
preserving both the maternal and fetal well-being.
Yeah. It's preferable to do the serum digital level. Flecainide, we don't have any facilities to do serum level of flecainide. Ideally, it should be done, but we don't have facilities. But as digoxin is freely available everywhere, so we can always monitor the serum digoxin level as well as, even though the loading dose has been mentioned here, again, hardly our patients tolerates that much dose. In the moment after 2-3 tablets, they start nauseating, vomiting, as well as they are pregnant. So all those issues starts off. So it's very difficult to load that much drug as well. But flicaride is usually reasonably well tolerated, even though the side effects, both are most of nausea, vomiting are the commonest side effects in both the drugs. So flicaride is more well tolerated. And as we do with pulse monitoring is the one thing, and as compared to sotalol, the bradycardia is not much very common with this flicaride. But sotalol, when you give 160 milligram or 320 milligram, definitely we should have eye on patient's pulse rate as well as the ECG, QTC, all those things to be monitored. But here in flecainide, we can order the ECG maybe of 3 or 4 days later. That's what I do it. And then weekly basis monitor. And after 3-4 days, the dose is fixed. I don't much bother about the ECG. But as long as serum level is maintained, a couple of levels should be on follow. If it is okay, it's fine once it reverted to thing. The average time taken to thing is, so varies literature. Some studies, 5 days, some study shows 9 days thing. And but this high dose flecainide, the studies, the only study showed the 3 days conversion rate. Most of the regular doses are showed 5 to 9 days to convert to the sinus rhythm. But in our population, so keeping the patient careful monitoring for that many days in the hospital, careful monitoring, it's also quite challenging. So, that is the thing. And when they converted, always follow-up can be done with the local obstetrician who's referred back to the obstetrician. And weekly once monitoring the fetal heart rate should be okay. That's what I practiced. But again, these are all my limited experience, and this all the literature also suggests that no, there is nobody discussed how they manage the patient after discharge before delivery within that 5 weeks, which you are asking 4 to 5 weeks. What is any protocol is there? I think no literature has described that. But simple common sense only practice, maybe weekly once we can monitor these patients.
I think there's a good question from Ajay about beta blockers, because that is quite intriguing. So we have a couple of comments in the chat about that, of the possible reasons why beta blockers are not used. Deepak has said it may be because of IUGR, and there's another message from Tanuja Karande saying it's probably because fetal myocardium has less beta blockers. So I think these are possible, but again, like you said, especially atrial flutter presents very late in the gestational period. So it's almost a newborn, and in newborns, we do use beta blockers. So I'm still not sure that's the complete answer, but probably earlier in life, I think these also might be concerns of producing IUGR or this. Couple of other comments in the chat section. One was Dr. Ashish Nabar had mentioned that it's a little surprising that you see this much reversion to sinus rhythm with sotalol, because sotalol typically has reverse use dependence and is more efficient in preventing AF than in converting AF to sinus rhythm. So that was one. And about maternal safety, which I think we have discussed, because even though the doses are higher, it is asked, is it possible that lower doses might work in Indian mothers? Or if I may rephrase, I mean, do you think we need to weight adjust the dose of flecainide that we give depending on if it's a smaller mother?
Yeah, so the other case which I showed, 30 weeks of gestation on SVT, which I showed, I used only 200 milligram of flecainide. So fifth day it's reverted to sinus, and it has been maintaining sinus for long. Yet to deliver the baby, still is 4 weeks over. They're maintaining. Maybe next couple of weeks expected date of delivery. With the 200 milligram, she's able to convert it as a single thing. So
I guess especially.
Yeah,
especially if there's no high drops, I think if there's no hurry, you would probably
correct.
start with slower doses and see.
Correct, exactly. So when you don't feel the risk of hydrox is not there, so when your patient is under a close follow-up, so then you can start off the low dose and then we can titrate.
Dr. Yadav has
Raja, I think we are moving on with time. Should we move on to the next talk, or Are there any more
Yeah.
comments?
Just okay. There are a couple of comments from Dr. Yadav. I think just is there any role for disopyramide in fetal SVT? And another is whether you can recognize fetal WPW. So I guess WPW pre-excitation might be difficult to recognize on a fetal echo. I'm not sure it can be done. Probably you would be identifying a tachycardia.
Yeah, unless fetal cardiography, if you do it,
Right.
excitation,
Otherwise,
that is
that's
the only
not
thing.
this.
And regarding Dr. Ashish numbers, this sotalol, there's only 36 patients. In that 36 patients, only 18 patients received sotalol. They had a higher conversion rate. These numbers are very small. We can't draw much major conclusion out of it. So that's why in our patients, still the common drug is digoxin and plecanate. So,
okay. Hello.
Fine.
Yes, Dr. Yash.
Yeah, Ajay, sorry, I missed a little bit, but I had one question for Karthikeyan. Is that this magnetocardiography, is it really accurate? And second, why has it been so difficult to develop a fetal ECG machine? Because there are a couple in the market, but I don't see anybody sort of using it in India or most places in the world.
Yeah, fetal ECG, I haven't gone through the literature. It is a mode of thing, but it is failed to come to the clinical significance because of the technical challenges. It has not been FDA approved also. Those who developers not even applied for the FDA approval, I believe. So it has stopped even before that. So it has not been approved by any of the authorities to use it. So that is the level that is there. But the magnetic cardiography, of course, so it is it can whatever the tracing I could see, it is I don't think anybody is having in India, but whatever the research centers might be following that. But the tracings are pretty good to draw a conclusion, especially arrhythmias, long QTs, or PVCs, or atrial ectopics, or blocked atrial ectopics, which can be easily identified with this. It's a pretty clear tracings. Of course, the magnetic-based ECG has to be clear-cut magnetic proof room and all the things as per the guidelines should be maintained. But it is a tracings usually pretty good to interpret it, easy to interpret it.
Okay.
So we've done some research with magnetocardiograms in collaboration with another center. So basically, you need supercooled sensors and a magnetically shielded room. So it becomes very difficult to set it up in a hospital setup. And I think for a fetal ECG, you need good subtraction of maternal ECG, and it's again that, like you said, technically challenging to record it. So I think that's why they have not caught on. So I think, like Dr. Ajay suggested, the next topic is again something that is going to provoke a lot of discussion, and I think we are 8:50 already. So thanks very much, Dr. Karthikeyan, for an excellent presentation. I think we will move on to the second presentation from Dr. Ajit Tachil, which is again another vexing problem of patients who have a Brugada pattern. It's always a very difficult decision on how to manage these patients. So, Dr. Ajit, please.
So hi, good evening everyone. So let's get started on this thing about which, well, I don't know a lot. It's a rather confusing topic. The more you read, the more you figure out that most people have not figured out how to go about it. But anyway, so I'll put a little bit of the Indian perspective here because we don't have access to some of the tools that the Western countries have. Now, first up, coming to the diagnosis, the HRS and the IHRS and all the societies still go by this criteria. The original one was V1, V2, V3. I think all of us know that V3 was removed from the diagnostic criteria quite a while back. So it's type 1 ST elevation of 2 millimeter or more in at least 2 leads among V1 and V2 positioned in the second, third, or fourth intercostal space. So we are supposed to position in the fourth space, 1 space above, and 2 spaces above. This may be during a spontaneous type 1 pattern or during an IV provocative test. I had some confusion on where to place the leads during the IV provocative test. I clarified that with Professor Brugada during the IHRS. He said very clearly, you put your leads in the second, third, and fourth intercostal space, whether it is for a provocative test or whether it is for to record your spontaneous ECG. Other spaces have no value, which makes sense because on the RVOT. But, well, now the question is when to do a provocative test. Now, I've written here my indication. So let me give an example. This is a real example. A 34-year-old lady, her brother, who was 28 years old, had a sudden cardiac death, just collapsed and died with no known comorbidities or diseases. and she had Brugada pattern, which was just less than 2 millimeter elevation, HT elevation. And she had recurrent episodes of pre-syncope, multiple episodes of giddiness, usually during the daytime, usually standing, while standing. The history of syncope was more suggestive of vasovagal than Brugada. But she got really scared because she got an opinion on her ECG from multiple physicians. Now, should I test this patient? I chose not to test this patient because I still feel that if we go around testing a patient whose history of syncope is not typical of a malignant cardiac syncope or an arrhythmic syncope, we will just create more confusion. That's just my perspective. So I think we should choose for testing only those patients where the test will make a difference in the management. So that is my perspective. We could discuss that. So that particular patient, what I chose to do is, I chose to do a tilt test just to prove to her that her pre-syncope is not due to Brugada, that it is due to vasovagal, even though it was obvious from the history. Now, as far as provocative tests are concerned, there are IV drugs and there are oral drugs. I listed the dose of the IV drugs there. The oral drug is by, well, just trial and error, we just hit upon it. And it's mostly the only publication on this from Sri Chitra, but I think by now all of us follow the same routine of giving 400 milligram stat. And we must take care about the ECG positioning during the provocative test. Now, how good is the provocative test? Well, the IV provocative test, as per the original description, is excellent. So this is how they did it. It was done in a very proper manner. 58 patients with type 1 Brugada pattern and VF or aborted sudden cardiac death. So there is absolutely no doubt about the diagnosis. Out of them, 34 did not have a type 1 pattern at follow-up, and these 34 were chosen for the provocative test. And these were compared with 53 patients who never had a type 1 Brugada pattern or never had a VF and never had a sudden cardiac death. And all patients in the who already we knew to have a Brugada turned up positive on the IV provocative test, and all patients whom we knew did not have a Brugada turned out negative on the IV provocative test, putting the IV provocative test as virtually 100% sensitivity and specificity. Of course, we are talking only about 34 patients in one arm and 53 in the other arm. It's not a big number, but it's just to say that the IV provocative test is a pretty good thing. As far as the oral provocative test is concerned, we really do not have that sort of data on the oral provocative test. So that is another reason why I'm a little conservative on subjecting a patient to the oral provocative test, because we often have access only to that. And along with the uncertainty of the true positivity and negativity of the test, if we also have uncertainty of the history of syncope, I think we probably should not proceed to that test. Now, as far as the test per se is concerned, it usually becomes positive in 2 to 3 hours, meaning properly positive. That is 2 leads showing 2 mm ST elevation. But in most patients in whom it's going to become positive, at least in my experience, within 2 hours, the ECG will start changing. We know it's going to become positive. And it results in about 5 to 7 hours. Like I said, we do not know the sensitivity and specificity. The only data we have on this is this paper from Sri Chitra, where the idea was not to check the sensitivity or specificity of the test of that paper. That was to see if any of the clinical variables would predict positivity on the oral flecainate challenge test. And it was a small number. In that small number, they found that family history of sudden death actually predicted positivity on the oral flecainate challenge test. But more important than that, I think the takeaway from that paper was that the oral flecainate challenge test was safe. And we got these numbers on when it will become positive. They also gave IV flecainate to few patients. Just 4 patients received IV flecainate. Those numbers are too small to compare between IV and oral. 25 patients at oral and 4 patients at IV. But this is what we know as of now about the oral provocative test. Now, the diagnostic criteria that I told is what was endorsed by the societies. A group of experts met in Shanghai for 5 days, and they were uncomfortable to say that an inducible type 1 pattern will make a diagnosis of Brugada. They've written this very clearly, that we are uncomfortable in saying that an inducible type 1 pattern makes a Brugada. So we need to change it. And this Shanghai score is what it came to be known as. was not based on any prospective evaluation of criteria. It is just based on expert consensus. So the expert consensus was that you need at least 3.5 points to call it a probable or a definite Brugada, and the 3.5 points is reached straight away. So there are 4 things. There is ECG, clinical, genetic, and provocative testing. So ECG is the only thing that makes it definite Brugada is a spontaneous type 1 Brugada. Fever or any other fever is Brugada during fever is considered only 3, and type 2 or type 3 converting to type 1 is considered given only a score of 2. So unlike the societies, the Shanghai score says that no, you need to spontaneously see Brugada to call it Brugada, or you should have. So the ECG is mandatory. At least one of these 3 things on the ECG is mandatory. And the first thing on the ECG, spontaneous type 1 pattern, is diagnostic. Now the clinical history is the history that most of it would take, but the unexplained cardiac arrest, 3 points. So unexplained cardiac arrest with any of those ECGs, it makes it a Brugada syndrome. Nocturnal agonal respiration with any of those ECGs makes it a Brugada syndrome. A suspected arrhythmic syncope with any of those ECG patterns makes it a Brugada syndrome. But if the syncope is unclear, of unclear etiology, then it gets only 1 point, which means that you need a type 1 pattern on the ECG to make it a Brugada syndrome. So this is where I think provocative testing should come in. So only when the syncope is unclear, if you do a provocative testing, as per the Shanghai score, so the type of syncope is unclear, and we do a provocative testing, and it converts to type 1. So the total score still adds up to 3. It still doesn't become Brugada syndrome as per the Shanghai score. So that is behind my rationale of not doing a provocative. So why do that provocative testing unless you have something more? So except, of course, for the validity that we can tell these patients to probably avoid the drugs which precipitate BF in Brugada syndrome. They also gave some points to AF or Flutter, some points to family history. They gave 2 points, which is far more than any other score is given. They gave 2 whole points to a first or a second degree relative with a definite Brugada syndrome. So it is a second degree relative getting a Brugada syndrome is as good as a suspected arrhythmic syncope in the Shanghai score. This is something which virtually every other author disagrees with. But the Shanghai score says that if a second degree relative has definitely Brugada syndrome, it is as good as having a suspected arrhythmic syncope or a nocturnal agonal respiration. Well, and the unexplained family history, well, it's a 0.5 point, so we really don't need to get into it. Genetic test is, well, I think it's just put there for the sake of putting it there, because nobody really knows what exactly is a probable pathogenic mutation. Mutations have been found all over the SCN5A gene in multiple areas of the SCN5A gene in Brugada syndrome, and we really don't know which of them are pathogenic unless we identify that mutation from a proband. Now, after the Shanghai score came out, a Japanese group validated the Shanghai score in a separate Japanese cohort. It was independently validated. It's a fairly reasonably good number. 393 patients, 97.3 month mean follow-up. And they took it one step beyond. They said it is not only diagnostic of Brugada, it actually prognosticates future events. That is, they classified the Shanghai score again into A, B, C, and D. And they said that a Shanghai score 3 or less means a 0% event rate at 10 years. No, that's the news that everybody has been wanting to hear. Which patient with Brugada syndrome has a 0 risk? So this is the news that everybody has been wanting to hear. And they said that the Shanghai score is so perfectly prognostic that if you have a less than 3 or less than 3 points, your event rate at 10 years is 0%. And that the event rate goes up proportionate to the amount of Shanghai score. So they said it's not only diagnosis Brugada, but it's also prognostic. Now, while all these things were going on in China, something similar was going on in Europe. This is by Brugada's group and some of his co-workers from neighboring countries. They came up with another score called the Sierra score. It was, unlike the Shanghai score, it was not built by expert consensus. It was formed from a derivation cohort and then validated in a validation cohort. That too had an 80 months follow-up. And they used rather different types of parameters. Spontaneous type 1 is always there. Now, these things get a sinus node dysfunction gets 3 points here. So it's totally off. The sinus node dysfunction or the equivalent of sinus node dysfunction gets 0.5 points in the Shanghai score, but it gets 3 points in the Sierra score, which is from Europe. The earlier familial, and EP study is nowhere there in the Shanghai score, whereas an inducible VF or VT in an EP study gets 2 points in the Sierra score. So this is basically the Sierra score. It was for risk stratification. It was not for diagnosis. As far as the European groups are concerned, diagnosis is based on the ACC, AHA, or the EHRA and the HRS. That is spontaneous or inducible type 1 pattern is diagnostic. That's it. They have no confusion about the diagnosis, about the society guidelines. So they are really looking at prognosis. Now the Sierra score said that this is also prognostic, but they looked at a whole lot of different factors. And they also had similarly fantastic numbers. The 10-year survival at a 0 score, well, 97.2%, not exactly 100%, 97.2%, but fairly good numbers. So now we have a fight, Shanghai versus Sierra. So since a whole lot of registries are there, a whole lot of patient data is there, a comparison was made from existing registry data on Shanghai score versus Sierra score. Both the scores were applied to existing registry data. And they did something good here because they looked at applying the Shanghai score and the Sierra score in patients with history of aborted sudden death, in patients with history of arrhythmic syncope, not any syncope, arrhythmic syncope, and asymptomatic patients, meaning without any history of syncope. And what they found, well, they found two things. One, that the dark line is the Shanghai score, and the dark line is the Sierra score, and the dotted line is the Shanghai score. And they found that both the scores perform more or less equally. But what is disappointing is that neither score was too good in the asymptomatic patient. Now, as we all know, that is the really troublesome subset, the asymptomatic type 1 Brugada, whether it is on provocative testing or whether it is spontaneous, but that's really a troublesome subset. Neither score was good in the asymptomatic type 1 subset. So we're more or less back to square one. And this is also 1,613 patients with 6.5 years follow-up. So comes the next score. This is published recently in JACC-EP. It's called a Brugada risk score. It's mainly population from UK. It's mostly an NHS-driven initiative, but a lot of patients also came in from Spain and from rest of Europe, a small cohort from Brazil. Now, they have a totally different approach. What they did is they collected all the individual registries, and their diagnosis once again was the HRS diagnostic criteria. 1,100. So all these scores are built on large numbers of patients. None of them lack in numbers. They're all built upon 800 to 1,000, 1,600 type patients, and they all have very long follow-up. And they looked at how many patients had ventricular arrhythmia or sudden death. 11 actually had sudden death. And they came up with this number, which you all know, that the spontaneous type 1 Brugada has an event rate of roughly 1.5% per year, which I think all of us know. Now, this was the factors that they looked at in deciding what would be the prognosis in spontaneous type 1 Brugada without a prior history of sudden death or cardiovascular collapse. Now, these are all obvious: age, sex, probable arrhythmia-related syncope. Family history of sudden death is defined as sudden death in first degree relative, age less than 45 years without history of CAD. The SCN5A mutation was looked at. Now, only 731 out of the 1110 were screened for the mutation. They looked at the role of programmed ventricular stimulation for inducibility and also VERP less than 200. But I'm not really sure if you can make any comment on this because only 406 underwent programmed electrical stimulation for inducibility, and only 436 underwent a VERP assessment. So I'm not really sure whether this score should be making any mention about this at all. They also looked at some new ECG things which were not part of the previous course. These I'll explain later with example. A significant S wave in lead 1 was called a 1 millimeter deep or a 40 millisecond wide. That's 1 square deep or 1 square wide S wave in lead 1. They also looked at these things. The AVR sign, that is a 3 millimeter AVR in a 3 millimeter R in AVR, or an R more than 75% of the Q in AVR. a peripheral Brugada pattern in at least one lead. This looks like a very frightening looking ECG. Never seen one as bad as this, but they looked at the significance of this, a peripheral Brugada pattern in at least one limb lead. And they also looked at the presence of early repolarization along with Brugada in at least 2 inferior leads or 2 lateral leads. And they also looked at the significance of a fractionated QRS, defined as at least 2 spikes in V1 or at least 4 spikes in V1 to V3 put together. So here V1 has 2 spikes, 1 spike here and 1 spike here. So they looked at all of these and they found that only 4 things make a difference. A type 1 Brugada pattern in peripheral leads, a spontaneous type 1 Brugada, that everybody agrees. A spontaneous type 1 Brugada is a higher risk than any in all these scores. They also said that a probable arrhythmia-related syncope, that also everybody agrees. A spontaneous type 1 Brugada and a syncope which sounds definitely like an arrhythmia, well, is troubled. I think those 2 things everybody agrees. They also said that a type 1 Brugada in peripheral leads and an early repolarization peripheral leads is predictive, whereas all the other things in that previous chart were not predictive. Now, how do you predict? It's a pretty complex calculation. You need to enter all these things into this thing, and it does some mathematical calculations and it gives some risk points. It's not 1, 2, 3, 4, 5 points types. So, and they said that the risk points equate the 5-year predicted risk of ventricular arrhythmia sudden death. Now, this is just recently published and it's not been validated by anybody else, but all these confusions exist. Now, coming to EP study, we really do not have enough data from multiple centers on the utility or futility of the VERP more than 200 number. So I just stopped looking at that because most of these studies have not specifically looked at that. Only limited studies from limited centers have looked at that. But most studies have looked at the inducibility of VT or VF, and most studies agree that it must be induced with 2 extra stimuli, not with 3 extra stimuli. So this is a pooled analysis of all of those studies which have looked at it. Now, we must acknowledge that these are highly influenced by the finger registry and the prelude registry. 44% of the patients came from the finger registry and the 23% came from the prelude registry. But to me, the most important part when we discuss with our patients regarding EP study is this part. The pooled analysis said that if the patient has syncope at presentation, then whether you have an inducible arrhythmia or you don't have an inducible arrhythmia, your hazard ratio is pretty high. It's 2.55 compared to the standard even if you don't have inducible arrhythmia. It looks like if you have a syncope at presentation and a spontaneous type 1 ECG pattern, it doesn't, much utility. This is basically what I discuss with my patients who come asking for reviews. I ask them straight away, look, if you do not have a syncope or a come back. If you do not have a syncope or a spontaneous type 1 pattern, then if we have a positive EP study, your chance of sudden death is 1.7%. If you have a negative EP study, your chance of sudden death is 0.8%. And if you don't do an EP study, your chance of sudden death is 1%. So I ask them straight away, look, if I told you that your chance of sudden death changes from 0.8% to 1.7%, will your decision regarding an ICD change? See, from our perspective, at least we cannot go by, we have to give a little more personalized medicine depending on our patients. It's a good thing and a bad thing that we are not bound by the guidelines. But this is exactly what I ask my patients. If I told you that your risk changed from 0.8% to 1.7% by doing a test, will your decision regarding an ICD change? You go back, think about it and come back. If you think your decision will change, if I change that number from 0.8% to 1.7%, do an EP study. Otherwise, don't do an EP study. This is exactly what I tell my patients. And most of them either put an ICD or don't put an ICD. Most of them don't come back for the EP study to help them make that decision. So other factors have been found to be prognostic in limited studies. I'm just mentioning them here because there are a whole lot of factors found to be prognostic. I don't think there's much point in discussing them because one study will find it prognostic, next study will find that it is not prognostic. So this is a suggested management by the consensus group. Avoid the drugs, avoid excessive alcohol intake, immediately treat fever. That I think everybody is clear. Electrical storm, we give isoproterenol. If there's a prior cardiac arrest sustained VT, you put an ICD. Now, presumably arrhythmic origin seizure or syncope, you put an ICD. I think up to this much everybody agrees. Here's where you have trouble. A spontaneous or a fever-induced type 1 Brugada pattern. What to do? You can see arrows going in all directions. Close follow-up, quinidine, well, we really don't have quinidine here, or put an ICD, well, nobody knows. Now, in this patient, should we do an EP study? Well, if you do an EP study and you find it positive, you get a class 2B indication for an ICD. So we really don't know what to do in this group. And this is the group where we really want to know what to do. So in this group, you have arrows pointing in all directions. And in our case, well, since we don't have quinidine, I think there are several anecdotal reports of quinine. I know that it works in some patients because I've definitely seen it work in 2 patients. I know that there's a patient who stopped quinine and started getting recurrent episodes of non-sustained VF, who was on an ICD, and 3 days after he restarted the quinine, it just disappeared. I've treated 2 patients with quinine. I think all of us have anecdotal experience of treating with IV quinine or oral quinine, but we don't have any data. So now I'm going to a case example. It's a 65-year-old male who had recurrent pre-syncope, and in the daytime he would occasionally feel giddy but would never fall. One day he was found unconscious in bed by his wife, and he was, the wife tried to wake him up. He wouldn't move. He was totally not moving at all, and then suddenly he came around, and he had no recollection of what happened. A Holter was done. This was done. He was being managed at another center by a cardiologist. It showed multiple sinus pauses more than 2.5 seconds a day in the daytime, and also sinus bradycardia, and he got a dual chamber pacemaker. Now, what is glaring here is that people with sinus node dysfunction rarely become unconscious in bed at night. It's an extremely rare thing to do, to have extreme prolonged duration of unconsciousness while lying down in bed at night. He had 2 episodes of syncope, which were very clearly suggestive of aborted sudden death 1 year later. And this is ECG. Because the ECG is not completely diagnostic of Brugada, but this is taken from a standard lead position. The next thing to do would be to put it in a superior lead position, one more space above, and if you require 2 more spaces above. But since we have a pacemaker inside this patient, we don't really need to do that. We just need to interrogate the pacemaker. And this is what it shows. The 2 episodes that the wife mentioned were on 29 January. It was 1 episode. If we put all of this together, it lasted for about a minute. And another episode on 2nd February. This episode lasted quite a while. The pacemaker all put together has recorded about 3 minutes of VF. But the wife says that the patient was unconscious and thrashing around and not breathing, agonal respiration for much longer than that. There was also 1 episode in December 25 which went unnoticed. Very surprisingly, when he went back and what was done is he was sent to the neurologist because he was having seizures at night. Since he had a pacemaker, he could no longer have bradycardia at night. The possibility, what I'm trying to highlight is that we must take the history of the syncope properly. Now we know that we are going to see this when we interrogate the pacemaker. So interrogate the pacemaker and you see this, and it's very obvious what's going on. So the cause of he has sinus node dysfunction and Brugada syndrome. So it was upgraded to a dual chamber ICD. And on May 17th, he came with a shock. I told him I tried to get quinidine. In the meantime, there's a drug called quinine available. I'm not sure whether it will work or not work. You try to get quinidine, we'll see what happens. If you get recurrent shocks, we can think about ablation. Then on 6th June, he got 3 shocks in a row. And I told him, okay, come over, let's check if it's an appropriate shock, inappropriate shock. In 2 days, he got another 2 shocks. And by this time, he was totally psyched out. He was no longer sleeping at night. He said, you do whatever you want. I don't want these shocks anymore. I cannot sleep at night. So he was taken for ablation. Now, one of the things we have here is the lead position for ablation. So this is how I would put the leads for any Brugada ablation. V1 and V2 are in standard locations. V3 is where it is, but I spread out V4, V5, V6 in just about 1 space above it's in the 3rd space. Now, there's a good reason why I didn't go up to the 2nd space. I actually interrogated the 2nd space, and I found that in the 2nd space, the ST elevation is not as much as in the 3rd space. So I put it in the 3rd space. So that's one thing which we need to keep in mind when we are doing ablation for Brugada. find out which space shows the best ST elevation and position the leads in those spaces rather than just place in V1 to V6. The second thing is, well, all the current studies say that you're supposed to give one of the IV challenge drugs during the ablation, but we don't have any IV challenge drugs. So for this particular patient, and whenever I do have to do an ablation, I've not done a whole lot, I've done only 5 of them. Whenever I have to do an ablation for Brugada, what I do is I give 400 milligram of flecainate about 1 to 1.5 hours before the procedure, because I know that the peak effect of flecainate will be about 2 to 3 hours. So I want to be mapping when the peak effect of flecainate is there. So these are 2 things that I do when I have to ablate a Brugada, and this is the ECG. The best ST elevations are in this patient actually are in the standard spaces, V1 and V2. And we also have some ST elevation in V4 here and V5 here. But the best ST elevations in these places, in this patient are here. This also suggests that we might get it not exactly near the pulmonary valve, but a little below the pulmonary valve is where you'd expect the substrate to be. Now, once you go epicardial, well, one could go anterior, it is much easier, but I prefer to go posterior simply because I'm more comfortable with the posterior approach. But one thing which we need to be careful if we go posterior is that we need to go across through the pericardial sinus. Unless we go across through the pericardial sinus, once you go across through the pericardial sinus, it's very easy to get anterior. Just flex the catheter and you have access to the entire RVOT area. But if you do this, we'll be struggling throughout the procedure. That is, here instead of crossing across through the pericardial recess, it's gone on top of all the great artery, the pericardial reflection on top of the great artery, and come around here. The catheter will follow this, but will stop here. From here, it will be very difficult to get across the RVOT. We'll stop somewhere in the appendage area. So it's one thing. Another thing which we need to be careful if we take the posterior approach. Now, another thing regarding the mapping. So this is the map of that particular patient. This is the epicardial map. This part is the endocardium. This part is the epicardium. Now, we have to always map the endocardium for 2 reasons. One, there may be endocardial abnormality. 2 is to see whether what we are getting in the epicardium is genuine epicardium or whether we're just poking with the catheter. You see this map, this part of the epicardium, I totally ignored because it's just my catheter poking it forward. So the importance of the endocardial map is that I'm going to give importance only to this part of the epicardial map because this is the part that is touching the endocardium. The rest of it is just the catheter poking. So it's not surprising that I get low voltage here. This is the part where the catheter is poking. I totally ignore this low voltage. In fact, under this, I had normal voltage, but it wouldn't project onto the map. It wouldn't project onto the geometry because I'd already taken this particular geometry. And this is the usual scar. The scar settings I've used is 0.3 to 1.5. So you can see that there is some low voltage here. Nothing really gets totally scarred. Above this is the pulmonary valve. And these are the areas that I chose to ablate, and I'll explain why I chose to ablate these particular areas. I already explained why I chose not to ablate this area, because this area, by the geometry itself, I had suspected that it is not really part of the epicardium. I'm just poking it there. The other reason that I chose to ablate these areas are these are the areas where I got this typically described long duration signal. So these are what the signals look like. Almost invariably in all the 5 cases I've seen, they're about 250 to 350 millisecond duration long, which is about the duration of the entire QRS and that curved ST segment. And they're almost invariably, they're also low voltage, not extremely low voltage, but somewhere in the 0.3 to 0.5 zone. Now this area had low voltage, but no long duration activation. So considering that this area was poking out into the epicardium, had low voltage in the absence of long duration activation, I would definitely think that that is well, catheter poking. It could also be fat, but generally the RVOT area is devoid of fat. These are the other types of signals, get this long duration activation, plus some late potential. In this particular patient, I did not have too many late potentials. There were the green marks are late potentials. I ignored this because this was all on top of the pulmonary valve already. Under these, there were about 3 areas of late potential. That's it. But some patients do have more late potential. But the timing is about the same. It's always between 250 to 350 milliseconds after the local deflection. And some of them are these sort of discrete late potentials. Now, yeah. So what would be the best ablation strategy? Now, this strategy, what I'm discussing is exactly what was described by Nadimani in his paper. And you can see that here his epicardium does not have that bulge. But he described exactly this. Long duration, low amplitude potential. So this is the potential that I got. This is the potential that is described in that paper. But this is actually different from the ablation strategy advocated by Paponi. So this is the ablation strategy advocated by Paponi et al. That is, you give Ajmelin. Of course, since I can't give Ajmelin, I gave oral flecainide. And you take 3 maps. The duration map, so you look at the area where there is a long duration, the voltage map, and the activation map. Activation map, of course, has no meaning. But what is striking here in this map versus my map and the map that Dr. Nadimani had shown in his publication is the discordance between the voltage map and the duration map. I can't understand this. I couldn't understand this. Why the one area would have low voltage and another area would have longer duration. At least in my limited experience, the areas which had longer duration have also had lower voltage. It has not happened the other way around, that one area is only low voltage and not long duration. So I would think that there is some sort of error here. If that's my take on it. Of course, my experience is limited to 5 cases, but all the 5 cases, the low voltage has corresponded to the long duration. But this is the strategy advocated by Paponi. You ablate only the prolonged duration, and you might have discordance between prolonged duration and low voltage. Now, Postma et al., this was early experiences. They did a pure endocardial activation and a pure endocardial ablation. Similarly, there were initial papers from China and Thailand doing pure endocardial activation and pure endocardial ablation to normalize the substrate. And when I was with Narasimhan sir, this is 10 years back, more than 10 years back, there was one case where we also did a pure endocardial ablation with a discrete late potential. I agree that since the RVOT is a very thin structure, pure endocardial ablation might actually get into the epicardial substrate also. So, but this patient did very well with pure endocardial ablation. So this is what we had written up at that time. All patients had an epicardial substrate, except one patient who had only an endocardial substrate. But among the patients, this is just 5 patients. Among those 5 patients who had an epicardial substrate, 3 also had an endocardial substrate, and there was no particular distribution. It was mostly on the free wall, but some of them also had on the endocardial septum. Now, what would be the endpoint for ablation? Now, this is from Nadimani's paper. He clearly said that the abolition of the abdominal local EGM should be the endpoint for the ablation, which he stresses in his subsequent papers also, because that endpoint seems to correlate with long-term freedom from VF rather than inducibility. Inducibility is a very poor endpoint. Or abolition of the type 1 Brugada pattern during ablation. Even though most patients, the type 1 Brugada pattern is abolished, the abolition of the local electrogram, abnormal local electrogram, seems to be the key pattern. So coming back to that patient, so this was the baseline, this is the post-RFA. I ablated only those areas that I had shown. Those are the areas with the long duration electrogram. They also had the low amplitude. They went hand in hand, long duration and low amplitude. You can see that it's not completely normalized, but if you look at the amount of ST elevation, it came down from 0.28 millivolt to 0.14 millivolt. This is immediately on table post-ablation. This is 1 hour post-ablation, it's completely disappeared. 1 hour post-ablation, you take at the ECG, this is taken in standard lead position. It's completely abolished in a patient who had a persistent type 1 pattern. But if you take the ECG a little too late, we'll have pericarditis. This patient, I did put in 250 micrograms of solimidrol in the pericardium, like we usually do, like most of us usually do. But at least in my experience, most patients who undergo that extensive epicardial ablation for Brugada end up with pericarditis. And if you're a little too late in taking that ECG, what we end up seeing is pericarditis like here. And then it takes about 5 or 6 days to actually see the normal ECG. So my experience after of independent ablation of Brugada is limited to just 4 patients. All of them had persistent type 1 Brugada with frequent ICD shocks. All of them required only epicardial ablation, even though I mapped the endocardium. All of them had a resolution of Brugada pattern. In one of them, the resolution could be appreciated only 6 days after the ablation because pericarditis changes set in very quickly. All of them stayed shock-free for years. It seems to be a fantastic therapy in patients with recurrent ICD shocks. I know that currently there's a trial going on saying that, okay, if it's such a fantastic therapy, why don't we do it? There's a trial going on to that extent, or why didn't you do it a little earlier, just one shock? So among these patients that I've ablated, the results have been really good. One patient had a single shock 4 years post RFA. This is a patient who had 16 shocks in a day and 22 shocks in the week prior to the ablation. He went to one shock post RFA after 4 years, and at that time the type 1 pattern had recurred. This particular patient, I put an oral quinine 300 mg BD. There were no further shocks for 2 years. After 2 years, he had severe tinnitus. I stopped the quinine, but he had no further shocks for the next 1.5 years. So I'm not really sure the quinine worked in that patient, but I know that there's at least definitely one patient in quinine has definitely worked. So my conclusions are the management of asymptomatic type 1 Brugada pattern is still unclear, except avoiding precipitating drugs and treating fever promptly. I would do a drug provocation if the syncope is only suggestive of ventricular arrhythmia, especially considering that the sensitivity and the specificity of the oral challenge is unknown. It does not seem to have false positives. All the patients that I've diagnosed and the people I've talked to who have diagnosed with an oral challenge, of course, they're all oral challenge in a suggestive syncope history without a type 1 pattern, seem to have got some events at follow-up. A detailed discussion of the utility of EP study is required with the patient before considering EP study. And I mentioned this is the exact question I asked. Will change in yearly mortality from 0.8% to 1.7% change your outlook towards treatment of this disease, or change your outlook towards putting an ICD or not? RFA seems to have good result. I wouldn't say good. I think it seems to have excellent results. The abolition of the abnormal substrate should be the minimal endpoint. The best candidate for RFA is not clear. Probably we could ablate a little more than being very strict about very frequent ICD shocks, but we don't know the answer to that yet. Frequent ICD shocks, definitely RFA. Infrequent ICD shocks, considering that there was a trial to enroll patients with ICD shocks onto quinidine, but it stopped because of inadequate enrollment and very slow enrollment. I don't know whether maybe we can give quinine in patients with infrequent ICD shocks. So that's about all I can figure out about Brugada, and I would love to know the audience and the panelists' views on all these things.
Ajit, that was pretty good. Very detailed discussion and extensive description. Dr. Raja, your comments, and then quickly, it's gone on a little long, so quickly we'll have some quick discussion.
Mentioned, I think it was a very good presentation, especially covered a lot of practical points and sort of uncovered the areas that need further exploration. Like we need to really look at sensitivity, specificity of flecainide challenge and other issues, and also on the scope of ablation, whether it's likely to be more applicable in these patients. So I think we have only about 5 to 10 minutes for questions, probably, Dr. Ajay. So
yeah, I think so.
So let's see some of the questions that are here. So there is one, Suchit is asking which age is it safe to use flecainide challenge? So from what age onwards do you think?
Patients have not had any problem. And talking to Nambudiri, he also gives the same opinion. I have used it in a pediatric patient where the history was very clearly sounding very lethal, and I used the equivalent pediatric dose to the weight adjusted dose, and I got a positive result. I actually suggested an epicardial ICD because a child had a frequent history. The child is lost to follow, but I don't think age is a problem for flecainide challenge.
Right. And if Yadav has commented about you can use warm saline irrigation on the pericardial cavity if required if you're not recording abnormal electrograms to bring them out. So I guess that's
I've never done that because all I've done is on all patients I've done a flecainide challenge before I start the ablation. And I think once you put the patient on flecainide before the ablation, I never required this warm saline business to bring things in.
And he's also mentioned that the abolition of the ECG findings might take some time. Sometimes it's not evident immediately after the procedure, but takes some time.
That's true.
That's true. I mean, my one concern with giving drugs beforehand is whether you might end up with VF storm and VF storm during the
Yes,
procedure.
it
Do you
is
think
a
that's
big
a worry?
concern. I mean, I'm doing it. That's why I said it's an Indian perspective. I'm doing it because none of us have access to the IV drug, so we have to make do with it. If I had the IV drug, I wouldn't do it.
It's very difficult to reverse it if that happens. So
It's a nightmare because I thought about it very clearly. If I end up in a storm, I'll have to give isoprene, and if I give isoprene, all that abnormal substrate will disappear. So I'll be stuck with the patient with an epicardial access and nothing to do. So,
that's
all I did is
I've seen this procedure. I've seen the procedure being done by Papone in his lab, and he's a pretty fearless operator. Actually, they use adrenaline. They induce the changes, then they ablate, then give adrenaline again. They induce VF.
they give
They
3
are
hours
pretty
straight on
fearless.
adrenaline.
Yeah. So one thing I would like to ask is this going to be a one-off procedure? Because you're ablating there, you're probably producing pericarditis. You may have adhesions there, and you may not get a second chance to ablate anything. So do you have to do it once and do it right?
I think so, because almost all patients have pericarditis, and going by the results of ablation that have been published, the results are very, very good. So I think it is one. It will probably have to be a one-off procedure because of pericarditis, and two, one-off procedure is likely seems to be a very good procedure because most the reported ablation studies have very good outcomes. If you look at the Nadimani studies and Paponi studies and Rugada studies, like patients go from 22 shocks to 0 shocks, that type of outcome. So I think it should be a one-off procedure.
Ashish has asked about the risks of ablating extensively the RBOT epicardium. Like what powers do you use? Do you think there's a risk of perforation?
I've been using fairly high powers. One reason is, well, I don't want to miss any endocardial substrate also. I know that amounts to sort of cheating, but I ablate 30 watts at 17 ml per minute ablation on the cool flex catheter. That's pretty much close to the maximum that we do.
Regarding the epicardial approach, actually, we are worried about the arteries close by. But again, in Papone's lab, they do say that generally the arteries are well protected by fat, and again, they are pretty fearless in ablating.
I do the angiogram, of course, in all the cases. Fortunately, in those 4 patients I did, I not had to go near the artery.
So one other thing from Dr. Yadav was about using cilostazole. So among second-line drugs, do you think apart from quinine, quinidine, what else works?
Yeah, cilostazole has been shown to work. So yes, that is one option which we can follow.
Fine. I think since it's 9:35, and I think both were excellent presentations, especially giving very practical, teaching points for people who encounter these issues. So I think we can bring the session to a close. Dr. Ajay, I think your closing comments.
Yeah, thank you, Dr. Raja. And there were excellent presentations, Dr. Ajit and Dr. Karthikeyan. I think that was extensive experience and pretty good. Vanita, over to you.
Thank you so much, both of you, Raja and Ajay. You did an excellent job, and I should not stop before complimenting Ajit and Karthikeyan. They did a fantastic job. I was just mesmerized by both the cases we were discussing. So Dr. Yash is here, sir.
Yeah.
Yeah, please, sir.
Tell me.
Sir,
I know I enjoyed both presentations. Ajit, as usual, was incisive and always gives us some new points to ruminate. And the first presentation, unfortunately, I missed a little part of it, but I was very interested and I wish I could have. I'm definitely going to see the recorded version of Karthikeyan. So thanks, guys. And yesterday, Vanita, Sanjay Dikshit, Deepak and me have had a brainstorming session. And Vanita, can you give a brief summary of what we have discussed?
Sure, sir. We had a meeting discussing about our web series that we are continuing with the mini symposia and the grand round. So what we have decided that since we are going back to our normal working thing, and our attendance hovers around 45-50 people at a time. So we're going to have it this web series once a month, and once every 2 months we will have either a mini symposium or a grand round or some case-based EGM discussions with the foreign faculty, which will be starting from we will have one the grand round by Dr. Samuel Ashirvadam in October, on the first Saturday of October. And after that, we will be resuming it from January. Till January, we will be having once a month web series symposium as we had it today within our faculty, or whatever we can make the best use of international faculty also. But the mini symposium and grand rounds will start once in 2 months from January. And I don't think so we'll have anything in November and December looking into APHRS, online APHRS, and our own very own online IHRS that Dr. Ashish Nabar is organizing. So November and December we'll give it a miss. So from now on, since July on, I think we'll be doing it once a week, once a month. Most probably we decided on the last Saturday of every month. Because if we take first Saturday, then first Sunday is the DMDNB students course that Ashish is very nicely organizing. So it gets a little confusing and we are hard pressed on time. So we decided that we'll do it on last Saturday of every month. So in July we'll have it on the last Saturday, and in August and September also we'll have it like that. And October, there will be a change because we have already fixed the time with Dr. Samuel Ashirvadam for first week of October, first Saturday of October. So this is the update that we had, and we will be doing it in a little different way. We have discussed what else we can do, like involving the industry to propagate our web series. This is such a good academic content that we want to go for to beyond IHRS, like involving people from SAARC countries, from APHRS, and from European society. So we will be taking help of industry people to propagate it more, and to how to make it more lucrative for everybody to attend. The attendance is becoming a little issue, so that's why we are looking at more alternatives. Sir, anything else you want to add? I think that is all I can think of.
I think the IHRS, actually, I have just realized is probably, to my mind, what I am aware of, the only body, not even the HRS or the European Society or Latin American or others. I think the activities that we have undertaken over the last couple of years has been parallel, and therefore, since nobody else is doing it, we should widen our sphere.
Sure, sir.
As Vanita, very active participant. Every week we are getting new members of the people to join the IHRS. So for their sake also, and to make it more appeal, and let the world know what the IHRS is doing, and let them participate. That is the motto.
Yeah. Thank you so much for all your support, and see you in July. Thank you. Good night.
Thank you, ma'am. Thank you.